to McLeod's Medlive channel, which has Indian perspective and session summaries. So I'm Dr. Sanket Niwale. I'm the host for the evening. I'm representing medical team at McLeod's. We are at the venue of CSI 2019, which is happening in the Ashok Hotel, Delhi. Today we have with us Dr. Gregory Lip. He's from the University of Liverpool. He's a professor, Dr. Gregory Lip. We also have Dr. Satyedra Tiwari, who is a professor cardiology, SGPGI, Lucknow. Dr. Ajay Sinha, who is a consultant cardiologist, Paras, HMRI, Patna. So I would like to start with Dr. Gregory Lip, sir. As you have done a great research and a lot of evidence that you have generated on atrial fibrillation. So can you just, because heterogeneous, as atrial fibrillation itself is a very heterogeneous kind of a disease. So when in this condition, how can we have a uniform approach for managing a patient of atrial fibrillation, sir?
I think you hit on a very important point, because patients with atrial fibrillation, they present to a whole range of healthcare practitioners. Many patients with atrial fibrillation are managed by general practitioners, and very often they are even without symptoms. They may well present to an emergency room. They're managed by non-cardiologists there. They may present to non-cardiologists as well, specialists in the hospital. For example, post-operatively in the intensive care unit, patients presenting to the respiratory unit with a pneumonia, they may get atrial fibrillation. And of course, they may present to the cardiologists. And even within the cardiology department, those who are interested in cardiac arrhythmias and non-arrhythmias. But of course, the perception, or the misperception, is that general practitioners think the specialists in the hospital manage atrial fibrillation in a different manner, and the answer is no, they don't. The hospital specialists, the non-cardiologists, will claim the cardiologists manage atrial fibrillation in a different manner. No, they don't. Even within the cardiology department, the non-arrhythmia specialists will claim, well, the arrhythmia clinic, they manage atrial fibrillation differently. The answer is they don't. And the patient's at the center of all this, because the patient's going to get information which is different from the general practitioner, from the non-cardiologist, from the cardiologist, and then, of course, they're confused. In terms of managing atrial fibrillation, we all know the principles. They've been in textbooks. They've been in guidelines. And you can distill some of these principles, which have been described as pillars of management of atrial fibrillation, into something as simple as A, B, and C. This is the patient journey, the patient pathway. And what is A, B, and C? Well, A is anticoagulation, or A is avoid stroke, because that's part of the principle or the keystone of managing atrial fibrillation. So, and for the A, is avoiding stroke, and the default is stroke prevention, unless they are low risk. And low risk is a Chatsworth score of 0 in males or 1 in females. They are low risk, no antithrombotic therapy is necessary. Beyond that, patients with 1 or more stroke risk factors should be considered for stroke prevention, and that's anticoagulation therapy. Mm-hmm. So that's the A. So what about B? B is better symptoms. And why is that? When all of us manage atrial fibrillation, whether a general practitioner, whether a non-cardiologist, whether a cardiologist, we are primarily trying to manage symptoms. Mm-hmm. So this brings into consideration of the strategies of heart rate control or rhythm control. And then with heart rate control, there's various measures to try and do that. Rhythm control largely is whether you deal with cardioversion or whether you deal with catheter ablation, and of course the use of antiarrhythmic drugs. But by and large, for the B, it's managing and improving patient symptoms. And what about C? Well, patients with atrial fibrillation are heterogeneous. They're often elderly. They very often have many cardiovascular and comorbidities. Mm-hmm. So the C is proactive cardiovascular and comorbidity optimization. And that includes lifestyle changes. So what comes under the C? Managing the hypertension, managing the diabetes, managing heart failure, looking at managing for sleep apnea, mm-hmm. underlying cardiac ischemia. There's a lot of attention to lifestyle changes like obesity management, reducing excessive alcohol intake, and also the patient's psychological morbidity, because many patients, as already said, sometimes they already get confused by the different messages from the different healthcare professionals. Mm-hmm. We have also shown how these patients have high anxiety and depression. So if you don't ask for it, the patient is not going to volunteer. So at the end of the day, the A and the B and the C, that's a patient pathway. It's an ABC pathway. That can be followed by general practitioners. It's saying the same things. Can be followed by non-cardiologists in the hospital, saying the same things. cardiologist. They're following the same things. And the patient leaves my clinic now understanding the principles of management, which is A, B, and C. That's the ABC pathway. You could say as easy as ABC.
That's superbly and simplistically put, and would be, I'm sure, if that message would be leading to a very simplistic approach, and I think towards a straightforward approach for a patient from point A till the super specialist and getting the right message.
But more importantly, we have shown in a number of, firstly, as a proof of concept, and we looked at a trial cohort and we looked at observational cohort, and it's a remarkable consistency. Patients with atrial fibrillation manage and comply with an ABC pathway, the outcomes are significantly better than a non-ABC compliant. And one of these outcomes includes mortality, hospitalizations, duration of stay in hospital. But that's observational studies, and then you could say, well, that is not the definitive thing, and you need a randomized trial. At the European Society of Cardiology in August, we presented as a late breaker a cluster randomized trial using app-based management. So clusters were randomized to ABC pathway management using a smartphone app versus usual care. And what did we find? Patients who are managed with the ABC, randomized to ABC management with an app-based management, again, there's significantly reduction in the composite cardiovascular outcome, including mortality, including hospitalizations, including stroke, thromboembolism, and bleeding. So if you manage them appropriately by compliance with an ABC pathway, easy as ABC, these patients do better.
Wonderful. Dr. Tiwari, can I ask you about the Indian perspective and the Indian challenges that we can face with an ABC pathway?
Yeah, the atrial fibrillation is all we know. There we look after this problem. We see quite frequently in our day clinical practice. Mostly our patients are of rheumatic etiology. Valvular heart disease, one of the very important risk factor for atrial fibrillation. And in our day-to-day clinical practice in our clinic, less than 10% come with, without any reasons. There are risk factors like hypertension, diabetes, obesity, smoking, and alcohol, which are the main reason, modifiable risk factor for occurrence of atrial fibrillation in our country. There are non-modifiable elderly age and postmenopausal ladies. They do also have episodes of atrial fibrillation. So overall, the perspective of treatment and managing and the following these patients is little different from what
from the West,
said. And how to follow and what precaution one should use, probably our colleague Dr. Sinha will.
So, I would like to add thyroid problem as well.
Yes.
Hyperthyroidism is an important cause, at least in our country. And the other part is that the incidence of valvular rheumatic, particularly rheumatic heart disease, has come down, is coming down. So the more number of cases of atrial fibrillation because of hypertension and other comorbid conditions like obesity, obstructive sleep apnea, and many other conditions, they are increasing day by day, including a lot of coronary artery disease with atrial fibrillation is there. So the number of valvular heart disease come down gradually. A number of other degenerative problem and hypertension is increasing day by day. But that's one. Secondly, we pick up cases very late because our diagnostic methodology is not appropriate. So what we do, we normally when patient suddenly presents to us with a stroke. So first presentation would be stroke.
Miss the boat.
Yeah, miss the boat. Yeah, and then sometimes they come with failure. At the midnight somebody comes with atrial fibrillation, fast rate, and is orthopnic in the emergency room. So that's a big issue. So our presentations our patients present quite late, and they have a different kind of scenario, and they are not picked up early. So when the disease activity is a very early stage, like electrical activity, that stage we don't pick up. Because we never, like rural population and all, they never care for the irregular beats. Have they care about the irregular beats and got a ECG done, I think this would be very easy to
Absolutely, and I think that ties into what we discussed before, because atrial fibrillation commonly coexists with so many other comorbidities. The current guidelines recommend, since these patients very often have comorbidities, they're going to attend their general practitioner, they're going to attend their specialist. So these high-risk groups, age over 65, cardiovascular risk factors like, as you say, hypertension or coronary disease or heart failure, when they attend for their follow-up, feel the pulse. If it's irregular, do an ECG. And that's very simple measures, but of course there can be more exciting, whether it's artificial intelligence or
so what do you think, sir, what do you think, like atrial fibrillation which are asymptomatic, what is the best and cheapest methodology to pick it up? I mean, I would say that because you know our scenario is different from the West.
Absolutely.
Yeah.
Well, if you want to go by a strategy tested in a randomized trial, we did that. It was called a SAFE study, and this was actually very simple. This was based in general practitioners, and we compared systematic screening, so basically calling everybody up, versus opportunistic, and the opportunistic was particularly focusing on these high-risk categories of patients, age 65, hypertension, diabetes, COPD, heart failure, and don't forget, SAFE was done well before all these smart technology and everything else, done about 15 years ago. And then simple things, good clinical acumen, feel the pulse.
Yes.
Nice and cheap, do an ECG. Nice and cheap. None of this smart technology at that point, you know. And what we did show in SAFE was that opportunistic screening was more cost effective than systematic screening. And if the issue again is to, especially with rural communities, and you know, maybe the education for the awareness and detection, especially in high-risk groups, because the high-risk groups are going to walk in through somebody's clinic at some point.
Yeah.
Whether it's for a blood pressure check, whether it's for a sugar check, something like that. Feel the pulse.
Yes. And I just want to add what you said, that a simple screening of the echocardiography, then you can rule out, you know, various reasons why it has happened. And maybe you can see the various dimensions of the left atrium, and you can rule out the other structure, heart disease, especially the valvular heart disease.
What is your threshold of thinking that this particular patient will require anticoagulation? Is it 5 hours, 6 hours? Is it 24 hours? Is it 48 hours or beyond?
Okay. Well, firstly, I'll start off by saying what the evidence tells us. It suggests that you need a duration of atrial fibrillation of 24 hours or more before it actually does increase the risk of stroke. In terms of the devices picking up atrial fibrillation, it recommends or suggests that basically if it's with all these devices, there's an intrinsic precision. It has to be 6 minutes or more before you can properly be sure it is atrial fibrillation. So that's what the evidence says. In terms of practical-wise, if you're focusing on the necessity for stroke prevention, which is anticoagulation, in my view, it's driven by stroke risk factors. And why is that? We are dealing with a dynamic arrhythmia. So let's say you had a particular 1 week monitoring for atrial fibrillation, and you've picked up 10 minutes of atrial fibrillation.
Yes.
Who's going to say that the next period of monitoring you're not going to pick up 10 hours?
Yes.
And who's to say the next one you're not going to pick up 10 days? You don't
That's
know.
right.
So it's a dynamic arrhythmia, and if they've got multiple stroke risk factors, to be honest, it's better to be safe than sorry, and discuss with the patient and offer stroke prevention, because this arrhythmia changes. It is dynamic, and one of our studies last year showed that especially if you don't do anything, especially when they change from more persistent to sustained atrial fibrillation, is associated with strokes, heart failures, deaths.
That's right.
So, sir, now that we understand how, when, and how difficult it is to diagnose an afibrillation patient, once diagnosed, what is the modality of approach in terms of his medical management and counseling for this patient?
ABC, easy. I've already gone through that.
Yes.
So first would be anticoagulation, as you said, according to the CHAD-VASc score. So anticoagulation. So in anticoagulation, we have a vitamin K antagonist and we have NOACs. So which would be preferred, and who tosses over the other?
Well, I'll give you again what the evidence and my perspective. Well, the first point to say is warfarin or vitamin K antagonists, these are great drugs. They have been around for a good 5 decades, good track record. Now, what we do now know is that if you're using warfarin, it's not simply writing a prescription and forgetting about it. You must pay attention to the quality of anticoagulant control. So that's this parameter called a time in therapeutic range, TTR.
Correct.
If your TTR is very good, 65, 70% and above, the warfarin is associated with very low rates of stroke, very low rates of bleeding. And you could make the argument that the difference between well-managed warfarin, if the TTR is 70, 75% versus a NOAC, actually it might be quite small.
Okay.
Nonetheless, maintaining a high TTR is challenging. The patients also require regular blood checks for anticoagulation monitoring. And furthermore, there's all the challenges with warfarin about diet and, if it's, green vegetables and how they can interact, and drugs and everything else. These days, we're in the era of the NOACs. They offer particularly convenience. And at this congress, at the exhibition, I'm seeing you guys are so lucky. All these generic ones available. We don't have this in the UK yet. And the fact that NOACs offer, improve efficacy, safety, and convenience compared to warfarin. And by and large, majority of the international guidelines already say that NOAC should be the first option, if at all possible.
Do you see any difference in therapeutic efficacy amongst these 4 NOACs?
Well, all the 4 NOACs basically have been compared to warfarin. They've not really been compared against each other. And the data we have do suggest that all 4 are pretty good. There's very marginal differences between them.
Yes.
So, what is our approach in the AF clinic? Because compared to 6 to 7, 8 years ago, when you don't have a choice, only warfarin. Now, 2019, you're spoiled for choice. You have warfarin plus, in some countries, up to 4 NOACs available.
Yeah.
Yes.
And we tend to fit the drug to the patient.
Okay.
And why is that? You might have a patient at particularly high bleeding risk.
Okay.
We have the HAS-BLED score to try and quantify that. You might choose the NOAC associated from the trials or real-world data to have less bleeding.
Yeah.
And that's essentially the Bigatron 110, apixaban, or edoxaban in the clinical trials. There was less bleeding.
Yes.
Now, all the NOACs have a degree of renal excretion, some more than others. So if a patient has moderate to severe renal impairment, creatinine clearance hovering around 30 mils, I would probably not use the Bigatron, because the Bigatron is highly dependent on renal excretion.
Yeah.
And some of the best data coming through, at least from observational data, even patients with creatinine clearance under 30, apixaban is doing very well from observational data, even in dialysis patients. In US, it's not on the Indian label, so don't, let's not encourage that. So you can fit the drug to the patient, is what I'm saying.
Yeah.
So how is your approach when it comes to an AFib patient and the NOACs and vitamin K? What is your drug of choice? And
I think the bottom line is you have to control the modifiable risk factors, number 1.
Right.
And as Dr. Lev has said, that probably the apixaban is the most favorable, has reasonable less side effects, because you have to give for pretty long time.
Right.
That is the important thing one should take care.
Sure.
Only thing is, dabigatran has got is less priced in our country.
Yeah.
That's the big advantage.
Yeah.
So,
but it's a good drug as well.
Yeah,
You just
it's
have
a
to
good
be
drug.
just aware where the limitations are.
But
it's
only-
a perfectly good drug.
Yeah.
Study we were Dr. Kaul was discussing dabigatran. So most of us are using underdose, like 110 milligram BD.
Yes.
That's
Well,
what do you?
But
what do you
110 BID was tested in the RELY trials, one of the arms. And
Yes.
with 110 BID, you have basically similar efficacy to warfarin,
Yeah.
but about 20-25% less major bleeding.
Yeah.
So it's, as opposed to some of the other trials, the low dose is not really tested in a powered randomized trial.
Yeah.
Now, if the primary objective, as how the FDA put in their description, the primary objective is to prevent ischemic stroke,
Yes.
then the party line, so to speak, is that the default should be the Vigatron 150, unless they got characteristics where you should give the 110. So it's elderly patients, high bleeding risk, or if they got interacting drugs like PGP inhibitors like verapamil, for example.
Right.
So, but 110 is a perfectly
adequate dose.
good choice because it's been tested in a randomized trial, so
Yes.
you know where you stand in the setting of particularly those fragile group of patients, and if they're high risk of bleeding, you probably just be a bit more cautious with the one, and the 110 is reasonable.
Thank you.
So do you see any different or challenge when it comes to twice daily or BID dosing compared to the OD dosing? Do you see, do they have an advantage, or what is your opinion on this?
Well, I'll tell you the experience from our clinic. Most of our patients with AF very often have so many other comorbidities that they have a morning pill round and they have an evening pill round. So taking it BID doesn't, or once a day, doesn't really make so much difference.
Right.
There are some patients who have a preference for a once a day because they have already taken so many tablets. But most of the time, in the UK, the pharmacy tend to package them up in this little boxes. So it's already all done already for them. So one, morning pill round, evening pill round. So it's not usually that much of a problem. Do remember, all the NOACs have about a similar half-life. Yeah. So it's a very good question. Why are some once a day and some twice a day? But I mean that's you can get into a very perhaps a little bit boring discussion on pharmacokinetics, but nonetheless, in terms of us trying to manage patients,
efficacy, it's
do what was
adequate.
tested in the patients in the clinical trials.
I agree.
Follow the label.
Follow the label is the right way to go.
But where do you keep the choice of RFA in atrial fibrillation, radiofrequency ablation in atrial fibrillation?
Well, by and large, with the B of ABCs for symptoms management, there are a number of studies that in selected groups of patients, notably heart failure, where catheter ablation may improve outcomes. Do bear in mind the limitations of those trials. They screen something like 3,500 people to randomize 300. And so the numbers are ultimately not so large. Catheter ablation does have a role. The other trial, of course, is Cabana. In the primary intention to treat analysis, it's not different between medical therapy and ablation. But if you have an on treatment when they actually have the ablation, there is some suggestion of benefit. So I think it does have a role, and I suppose in my AF clinic, I offer the options to the patients. Very often, this is the sort of British patient mentality. They like to at least give tablets a go first, and if the medications don't control, they know there's another option
for RF ablation.
That's right. Yes.
And one should not forget that there are chances of recurrence even with
absolutely.
RF.
Their 30% will very often require second procedure,
which is quite high.
Absolutely.
Wonderful, sir. I think we had a great conversation today with Dr. Lip, Dr. Tiwari, and Dr. Sinha on the topic atrial fibrillation, its management. Dr. Lip has given us a very simple, uniform method of managing the patients of atrial fibrillation, which itself is heterogeneous in its nature. I think if that ABC, if we can follow, if everyone can follow in India, in Indian practice, I think we will have better patient outcomes and better patient quality of life and good future. So I thank each and every one of you for contributing and participating in this channel. Thank you, sir.
Thank you
very much.